Here we are in this very important session, very important early morning session, and all of us are grateful to the audience. All of you have taken time away from many other important things that are going on here to be here. So health, everybody talks about health, but does very little about anybody else's health. People get focused on their own and they think that as long as I'm sorted out, life is okay. But that is not so. South Asia, the region where we live, although there are some disputes about whether we should call it South Asia or not, has one-fifth of the world's population, but a disproportionate large share of the world's diseases, both communicable and non-communicable. Communicable, there's a history, also it's the climate, it's the crowdedness of our cities and lack of infrastructure. Uh, but also now there is a new phenomenon, which is a rising epidemic of non-communicable diseases, particularly type 2 diabetes. It's an epidemic now. It's almost impossible to find somebody of a certain age group who's not taking care at least. So in this situation, there is a lot to talk about. I have a great panel with me. To my left is Shobha Kamineni. Sh- Pardon me? Did someone say something? No.
No, no.
Okay. I have Shobha Kamineni. She is the executive vice chairperson Apollo Hospitals. Uh, those who live in India, I think most of us have either been to Apollo for themselves or to visit somebody. She's a pioneer. Apollo is a pioneer, actually, her father, in private healthcare pan India. Then I have Matthew Guilford. Matthew Guilford has an unusual job. He's co-founder and chief executive officer, Common Health, based in Malaysia, but he works in 3 countries, including Bangladesh next door. And Bangladesh, he tells me that he has a health insurance system which has the largest number of people enrolled. So I think there are lessons there that we have for India as well, because we are trying to build something like that in India. Then we have Melvin Oscar D'Souza. He's the general manager and corporate vice president Novo Nordisk. Anybody who's dealt with diabetes, with themselves or any member of the family, has seen Novo Nordisk on some label. Lately, they've been in news because I think one of their new molecules, which is an oral substitute for an advanced anti-diabetic, I think third line or
Yes,
fourth
now
line.
actually a first line now.
First line now.
Yeah.
First line, which got FDA approval, and we all carried stories about it. So his company is among the few companies which are at the cutting edge of research in many pharmaceutical areas, but especially diabetes, which as I said earlier, in the subcontinent is a very major problem. And then we have Karan Singh. Shashank, yeah. Sorry, and the lights there are not helping. We have Shashank ND, founder and chief executive officer of Practo. Now, Practo is another of those unusual companies. Practo, immediately, a layperson like me would think, oh, telemedicine means I can go Google WebMD and treat myself. Because once I know what drug to take in India, in the subcontinent, anybody dispenses any drug to you over the counter. Everything is OTC. But he does something more complex and more interesting than that. Uh, his company brings doctors and patients closer, so you can consult them on internet or on the phone, but also go and see your doctors, because India has a terrible shortage of doctors. So even in our cities, as he explains to me, say Delhi and Bangalore, the ratio of doctor to patient is 1 is to 500, but in villages it goes up to 1,000. So how do you get those villagers or those people who have such poor access to doctors access? And he now tells me that he has something like 20 million patients,
Yes, a month, yeah.
20 million patients a
20 million.
month, so more than 200 million patients in a year. So that is the kind of need that exists there, and that's why I'm particularly enthused about the new plan of this government to massively increase medical education in the country, because we are short of doctors in our country, and especially specialists, because the most expensive specialists in our country have the longest waiting period. Uh, and then we have Karan Singh. So Karan Singh is MD of Bain and Company. Uh, it's a consultancy. As you would guess, his job is to listen to everybody's problems and tell them what to do. He doesn't particularly have to do it himself, but he can tell them what to do. So it's a powerful and sizable panel. So I would request each one of you to speak for a couple of minutes. I will start you with a question. And I think I'll go, instead of just going like this, maybe I'll go like this and like this. And at any point of time, feel free to intervene when someone else is speaking without being rude. And then I will engage with you, and then the hall belongs to then the time belongs to the audience, to the hall. And finally, in conclusion, we'll have Indu Bhushan, who's CEO of our Ayushman Bharat program, one of the most important healthcare programs anywhere in the world right now. And he will have some concluding remarks. So, Shobha,
Me?
you first.
I got picked out.
So you are in a strange place right now, in the sense that on the one hand you provide the contrast to the health problems in the subcontinent, which is the best quality healthcare. The best quality healthcare at costs which are very high for the region, but very cheap globally. Uh, so, how does that help the larger public health problem? At the same time, the new plans that are coming up are now going to involve the private sector like yours. So how do you see this working out? And do you have better ideas going ahead?
Um, Interesting. But just to give you a bit of a perspective, I live in Hyderabad, and the last week I spent, people calling me. This is friends and people I didn't even know, but who had my number, and they said, "Can I get a bed in Apollo?" And we were full with this. And what were we full of? Not really the cases that Apollo wants to treat, but the cases that we had to treat. And it comes out of, this community problem. It was dengue and chikungunya. It was almost to epidemic proportions. And running a health insurance company that, I founded, I saw, I've always seen the spikes. So this year is actually spiked more than the last 10 years of whatever we've been doing in terms of claims. So I'm counterintuitive. I sit on a claim side that you don't want, and on the other side, we sit on the treatment side. So I'm seeing the whole cycle of what happens, and then of course I sell medicines. So we're all over the place. But having seen that, it's not a problem you want to have. And I think that I'd start first by saying that whatever we do for healthcare for all must start with a measure of seeing how we can the environment, and so
This you're
it's
talking
so
about
contextual.
Hyderabad.
Yeah, but it happens here in Delhi.
Because
Once
it's-
your rain start,
The Chief Minister of Delhi is claiming this year that dengue is down 90%.
yeah, but Delhi, it's NCR. So you're going to see those claims start spiking. What happened after the rains in Patna? You're going to see huge amount of spikes. So I think that this is something that I think that contextually that it's everybody's problem. So let me put that out there, that when you're talking about healthcare for all, let this be everybody's problem, that we need to have to sort out what is the infrastructure in our cities. We need to start working on some of these that are clearly things that we can treat and which are a problem around the subcontinent also. Now, moving forward, I think that Shekhar asked me, what are the models that we see? And Shekhar, we kind of do it all. Our telemedicine has treated 10 million people in rural areas. So we know how to take it out there. We are actually, from Andamans to Africa to everywhere, we have the largest telemedicine network, and we're doing this every day. So we understand that. But what we need is a model that uses the healthcare facilities, some of them that are available in India. And I'd like to talk about an interesting model that we took. And the government really wants to do more of this, because if you see that the top end spectrum in India, if you want to give great healthcare, is going to cost you upwards of 1 crore a bed. A crore is 10 million rupees a bed, you know, and you cannot, when you're paying 10 million rupees a bed, when you're paying for all the other real estate taxes.
$150,000.
So to others it's cheap, but it's expensive for India. 2 to 3 crores, depending on the facilities you put. And the cost of our proton, for instance, was I'm trying to convert it to dollars, was 1,200 crores. 1,200 crores is like 1.2 billion rupees.
Yes.
Yeah, so this is the cost that you're spending, you know, and you have to, and doctors' charges and everything. So to give great medicine, you really have to be out there and spend it. So there's a cost to it, you know. And these are things that you have to run as a proper business. So the way that you do it, keep that at one end of the spectrum. And like Shekhar said, we do it at 1/10. Most of these people would be traveling to other parts of the country. So there is that is one India. There are 20 million Indian families that spend the same amount as people in Europe do, middle class Europe. So there is a population that will require new facilities.
I think, sorry if I may interrupt.
Sure.
I think this is reassuring, but the best healthcare is one that you don't have to avail of.
Yeah,
So-
yeah. But coming down to the lower, I really think that Ayushman Bharat, why we all have to invest in it, is because this is something that will move to tier 2, tier 3, tier 4. And at that level, we have to find what are the new models. And it's probably not the Apollo model of building beds at 2 crores a bed. So we have to find that model, and this is something that we're all working with. And a great thing that we've done is we've taken over the in Chittoor, where my dad comes from. We've taken the government hospital and upgraded it, and we're doing it at Ayushman rates. So there are areas in tier 2, tier 3 that we can start building out, creating more public-private. And I'm going to stop there because I can keep on going on, but you know, the message is, let's get into some of things that we
Scale.
can avoid, and the other thing is
Yeah,
scale
scale is the issue. So Karan,
and technology.
you solve everybody's problem. So how do you solve the region's scale problem and cost problem?
Yeah. No, first let me say it's great to be here. And first and foremost, it's fantastic that health is a state and a government priority with Ayushman Bharat. And I would applaud what Indu is doing, which I think is absolutely a game changer for India. Just a couple of thoughts, Shekhar, as we think about the issues and the biggest opportunities going forward. You mentioned the tsunami of NCDs that unfortunately we're going to get hit by, or we are getting hit by. I think it's a huge priority that we need to address. And the challenge is, we all know the numbers about diabetes, cardiac care, oncology, etc. The challenge is about how the diagnosis rates are about 45 to 50%. So we are a sick population that does not know how sick we are. And given we are the hotbed of generics in this market, we need to be finding and treating much earlier and much more cost effective using lifestyle and generic drugs. And I think the point that you made is keeping people healthy is keeping them out of the hospital. So there's a paradigm shift we need to think about preventing and early treatment. Only then does the system become sustainable. Ayushman Bharat is a great step in the right direction, but I think how do we bring the emphasis on primary care, which is the early part of treating, and mass-scale screening for diabetes has to be one big priority. The second one I would say is a paradigm shift is required in terms of creating the right incentives. What do I mean by that? Today we are a fee-for-service system. I would say argue that this is a perverse incentive, and this is all about curative. We would love to think about more of a capitated, a pay-for-performance model that provides the incentives to keep people healthy. and keep them out of the hospital. The hospital is the most expensive part of the treatment. So again, I think a paradigm shift of how do we think about incentives and a pay for performance is the second thing. Third is the quality in this market, unfortunately, is hugely disparate. When you look at the accredited institutions, whether it's hospitals, whether it's diagnostic labs, we're talking about 1% that are actually accredited. So in any health system, for it to be sustainable, we need quality, access, and affordability all to be taken together. So I think a minimum standard of quality is essential because there's no point spending a lot of money when we're not clear about what is the outcome of that today. So I think quality has to be
So will you
expanded.
tell us something about maybe the most interesting case you've dealt with?
I
or
think
a
there is a
situation?
tremendous opportunity when it comes to health tech. So we are doing a tremendous amount of work with the leading health tech companies. And I think if you look at the next 500 million that are going to come online, our penetration of using health tech is actually very low. This should skyrocket. And the issues around access and affordability there are some very interesting solutions that health tech allows us to address, especially the issue of the lack of concentration of infrastructure, hard and soft infrastructure, in the smaller towns, which is where there's a huge population. So we're doing a lot of work when it comes to how do you expand health tech to the needy population. And I think with that also, Shekhar, it'll be good to get some discussion going on in that same needy population. It's the middle class that is the most vulnerable today. The insurance penetration rates there are about 10%. So we have very well taken care of in the BPL, thanks to what Indu is doing and Ayushman Bharat. The top end has great care. There is a very vulnerable middle class where I think we need innovation on insurance and on delivery, the same point that Shobna was making.
So the self-employed, I think, have the toughest time. So, Matthew, you have a lot of practical experience of this, and you're dealing with all strata of populations. In diverse countries, Bangladesh and Malaysia are very different in terms of their economic base and their social base. So, tell us a few experiences that you've had, and you've had these two lay out some problems and some possible solutions. So,
Great. Well, thank you very much. I mean, I think, when we started the journey in Dhaka, when I moved to Bangladesh 5 years ago, I think for us, when we think about health for all, it sort of comes back to this, right? I'm sure many of you have seen a sachet of shampoo, right? And I think, when we think about who we serve in health for all, the question is, how can we connect healthcare, design health products for a woman who's buying shampoo in a sachet, right? And when we talk about this idea of common health, which is what we've named the company, it's because we want health to be as common as going to your corner store and getting access. One of the things that we quickly discovered as far as barriers for this segment in Bangladesh was how do people pay for healthcare, right? And I think if you look globally, out-of-pocket spend on healthcare is roughly 18% of health spend. In South Asia, it's about 65. In Bangladesh, we did a survey in 2016, and we asked 1,100 people. This was with Nielsen, so it was scientific. We asked 1,100 people, do you have health insurance? And 3 people out of 1,100 had health insurance. So that kind of calibrates where we were starting. I think when we think about the answers and the solutions, it is absolutely about tech and these new models for lowering cost, increasing efficiency. I think it's also about distribution. And one of the things that we looked at is how can we reach into communities and villages? So, very quickly we found we were, for example, billing through telco airtime. So through a partnership with Grameenphone, which is the largest telecom business in Bangladesh. And we actually found that people didn't have enough airtime balance to pay for the subscription. So, many of you may see, I don't know if this is still the case in India, but scratch cards, right? So this is the way that people in many parts of the world used to buy and top up their phones. So we actually launched scratch cards. So this is 47 taka a month, so it's about 60 cents. And it has $500 in inpatient insurance, 10 minutes a month of access to a doctor over the phone, and then discounts at labs, pharmacies, diagnostic centers. So I think as we think about getting to this health for all tier, it is the technology, it is the business model, but it's also thinking through what can we learn from other industries as far as distribution and reach.
So what does it take to convince poor people that insurance is fair in principle, that insurance will not make a distinction between those at the upper end and those at the end at which you are engaging with them? And also then what do you do to make sure that insurance is fair?
Yeah, there was a quote from a guy from Ogilvy that said, health insurance is the hardest product in the world to sell. I'm curious about your view on this as well. It's tough to sell health insurance. And I think, we see a couple of barriers. So one is, especially for populations that are low income, there's a high discount rate on the future, right? So you're basically asking someone to pay now for something that, as we say in Bangladesh, inshallah, right? That hopefully they won't need to use, and they have to invest in it now. So that relevance is a challenge. I think, the other piece that we see is trust, right? Yeah, please jump in.
I cannot.
Please feel
running-
free to answer,
okay,
to toss questions at
Having
your fellow
run
participants.
an insurance company, what prevents adverse selection? Because if this is a monthly thing and you're paying 500 rupees, if I'm sick, I'll take this, and then next month I can postpone my surgery and I can come and avail of it.
Yeah.
So how do you do adverse selection?
So I would say we learned that one the hard way.
Okay.
So when we first launched, the intention was to cover any inpatient procedure because we wanted to be simple, right? So if and the rule was any hospital stay of 3 nights or more anywhere in Bangladesh, and we pay a flat cash payout. So we all know what elective C-section rates are in this
Yeah.
part of the world, right? So basically, we got killed.
would know.
We got killed by elective C-sections, right? So people were buying the product in 1 month, going to claim 100 times what the premium was the next month. So we've had to adjust the product. I think the other piece to this is we don't sell it just as insurance. And so it's the bundle piece. So in fact, what we do is we've shifted towards marketing it as it's access to a doctor with insurance. And so we have a pool of people that are buying the product because of the telemedicine piece that are not necessarily claiming. But I think to your point, it's chicken and egg, right? Because the typical potential insurance players in many places where we work will say, okay, you've got anti-selection. So now what we have to do is put in more rules, right? And then you put in more rules and then people start to lose trust in the product. And then you have more anti-selection and then you put in more rules and you get into this downward spiral where suddenly you don't have a book, right? So this is a longer discussion.
Okay. Yeah.
Well,
I don't want to sidetrack.
no, since you said inshallah about Bangladesh, in this subcontinent, because when there is when situation is so adverse, you do lean on God. So I think in India, most of the Hindi heartland, they say Bhagwan teri maya kahin dhoop kahin chaya.
Yeah.
So there are equivalents of inshallah. So our gods are kept busy.
Yeah.
Shashank, you deal with many of the issues that the 3 speakers so far have mentioned, and the next speaker will have some solutions for. But after problems gone out of control. So tell us about your experiences, because you are connecting so many people and so many people of very diverse backgrounds and very diverse economic ability to doctors.
No, thank you, and it's a pleasure to be here. I think the advantage of sitting in our shoes is the access to data. We have about 200 million users each year coming in, accessing information, accessing service on our platform, and we get access to a lot of user behavior and a lot of user data. And over the last 10 years, with all this data and other data available, it's very clear that India has high quality healthcare. That's the reason we all here use the Indian healthcare facilities, and we have a lot of people from outside coming in. But unfortunately, we're not able to use the same healthcare for everyone in India. So clearly an accessibility and an affordability problem. Through the data that we have 30,000 plus doctors, and we have noticed their schedules for years now. And what very interestingly is coming out of this data is that the doctors are all grouped in the metros, where the patient-doctor ratios is quite low, which basically means that it's much better than what the WHO prescribes. In the rural areas, it's much higher. That basically means that we have overcapacity in the urban centers, And we've seen data which suggests that over 70% of doctors have at least 30% of their time or more available. And then we have another India where there are lack of doctors, lack of quality doctors, and there's lack of access. Clearly, the answer is digital health, and how digital health through telemedicine can actually solve this gap. What we are also seeing is a very interesting point that was shared on this panel already, is that in developed countries, the number of doctor consultations per year is actually 10 to 12, but in India, it is 2 to 3. So more number of doctor consultations actually leads to a healthier society. More number of more easier we make.
Can I request you to specify that? 10 or 12 or 2 to 3 doctor
So
consultations?
10 to 12, an average individual in a developed nation does about 10 to 12 doctor consultations every
a
year.
year?
In a
Okay.
year. And when it comes to India, and we have the data for our set of cohort of users, it's about 2 to 3.
I think in India, somebody did 10 to 12. If the person is generally healthy, it will be declared an hypochondriac.
Right. I think it's also because of a lot of insurance coverage. I'll come to that point. But I think the larger narrative there is that we've also seen Indian users over the last many years increase their frequency of use from 3 to 4, and that's increasing. So it's on the increase. So what we need to do is be able to get doctor access to Indian consumers and bring that awareness that early access to a doctor means early detection. Early access to a doctor means less of self-diagnosis. And this is very, very critical. We're also noticing that doctor behavior is also changing, and an Uberization of doctors is happening, where doctors are more and more comfortable consulting irrespective of time and location. So they are ready to consult on phones, and so are consumers, where there's an increase in number of voice searches happening.
Can I interrupt you? Now, in a country where there's nothing such as prescription medicine, because everything is available over the counter. There is a hazard in doctors advising from a distance. It's the same as me going to WebMD or something and saying, I need this drug, and then going to my neighborhood chemist, or even to an online pharmacy. So there is an ethical issue. How do you address that?
So with every innovation comes come the risks, and so we have, I think one is self regulation, where we have quality teams that do it, but I think it's actually the government's role to actually put the right soft regulations in here. And second, I think the way to actually get telemedicine's propagation going, in my opinion, is to make it a part of insurance. And insurance companies can actually leverage telemedicine to actually reduce the costs and actually be able to do the screening that we spoke of. So one is to allow insurance companies to be more innovative and to include telemedicine as a legitimate means of healthcare delivery with the right guardrails placed. I would rather have a patient talk to a doctor and get medicines in a regulated manner than self-diagnosing himself. So there are a lot of benefits that one can derive out of the telemedicine.
Okay, just two quick comments on data. I think the power of data in healthcare is huge. I think one is, how do you use data in a more connected manner? What I mean by that is using the data from primary, secondary. Today, there is siloed data that each one has. That connectivity, the power of that will improve outcomes. The second point actually on data is, I think there's a massive opportunity to actually publish outcomes. So when you talked about poor quality, I think with the systems we have today and the connectivity, we need to be able to understand quality in a much more transparent manner. So I think just adding to what Shashank is saying, we can take data and literally leverage it to improve quality in a quite a substantial manner.
Well, I mean, these are very interesting concepts, and you need these if you want to scale up. But for somebody who spent a few years of life, a few decades of life, I'd say that there's something odd about a doctor who treats you from a distance, because today, even if you go to a specialist, usually the guy doesn't poke you in your liver or you feel your abdomen or your pulse. Doctor looks at the scan and prescribes something, and while the prescription is on, the patient is Googling for side effects, right? So there is a touchy-feely quality to doctor-patient relationship, which is disappearing because doctors are busy. So does telemedicine, is it convincing enough for patients? You could answer that question.
I mean, I guess what I would say is, so it depends on what you're competing with, right? So if you look at rural Bangladesh, where the option is a pharmacist who has no training, and that's how people are getting care. I think we find that for a lot of people, even rural people with low education levels, they recognize that it's a heck of a lot better. I think there's also use cases where people actually want some distance. So, my friend Ivy from Maya is in the audience today, who does a lot of work around women's health. If you're a woman that wants to talk about family planning, do you want to go to your doctor with your husband? Or is that actually advice that you would like to get in a confidential way? And I'm curious about with Practo, what types of use cases you see in this as well.
I think that's 50% of our users are women, although the internet in general has 30% users as women. So the three main use cases on Practo Telemedicine is one, women's health, two is psychiatry, which is mental health, and three is sexual health. Now these are social taboos in a society like India, and consumers are deprived of any solution, any professional advice. And I think for these, again, telemedicine can be a great leverage.
Shobha, you have any inputs on this before we come to Melvin?
No, I completely agree with the point of view, but I think that when it comes to a specialist, maybe the consults for an emergency, if or at night, or you really can't get a doctor at that time, telemedicine is absolutely essential. So we have to mix these. And to me, my biggest worry of these online pharmacies is that they're coming from a perspective of how many drugs can I sell. So then there's no perspective on habit forming, and I'm very worried, and I'm sure Melvin will talk about this, is about the antibiotics prescription. What happens if this whole population becomes resistant? So that resistance is something that we're not taking seriously enough. And I think that, so I would add that element into
Yes.
it.
So, Melvin, you are being blamed now. You are on the
I'm
flat.
saying, please take care.
I'm just
Yeah, of course.
just giving me a hard time. So, Melvin, your company works particularly in areas of chronic disease, chronic life-threatening disease, life-threatening or debilitating disease, and something like diabetes, which will debilitate you. Also, if you are not well-to-do, clean you out, because even though insulins become cheap now, but it's cheaper, but it's still quite costly, and even most of the diabetic medicine is costly. And then you, the evil, quote unquote, not my words, multinationals, you are to blame for many of the problems that come in our healthcare. So just hold forth for a couple of minutes.
So first of all, glad to be a part of this panel, but usually pharmaceutical companies are the famous beating boys, yeah?
Yes, absolutely.
And then you actually start working from a place where you see what is your role, what problems do you solve. I think if you look at diabetes, and Shekhar, you put it very nicely, because the biggest problem that we see is an average person comes very, very late into a clinic. That means and loss of close to 6 to 8 years before even you have actually identified that you have the disease. So we generally call diabetes is an emergency in slow motion. So by the time you have reached the doctor's clinic, the patient already has 2 or 3 complications. And that is the time when the pharmaceutical company comes in, usually people like us, because you are trying to give a medication which probably would have sort of exacerbated the disease so far that you are doing mostly a salvaging job. So as an organization, Novo Nordisk, you would have heard, or many of you in this room would have heard, I mean, we are, of course, within diabetes care, we are a company which is involved in protein, developments. What we see is, I mean, it's not that insulin-like product can solve the issue, but we believe working in partnerships is a key to actually making or finding a solution to a problem. So how do we get the diagnosis rates up? How do we make sure that this doctor-patient ratio can actually bridge those gaps? And I think most of the work that we do in India is also revolving around these issues, trying to build a bridge for accessibility, trying to build a bridge for affordability, and also trying to bridge towards making sure that we have some sort of way how to make our products available. it's not easy because India is such a vast country. A product like us, I mean, the number one product in the pharmaceutical industry for that matter, it takes time and a little bit of distribution knowledge, like what Matthew put in, is to make sure to get this product at the remotest part of the country. And that itself is a job.
You're talking of insulin?
Insulin.
Insulin.
Insulin. And for us, it's not that once you keep that insulin in the remotest part of the world that the patient is going to buy it. It's simply because the patient again has to travel back to the city to get themselves diagnosed. And I think as an organization, we are trying to solve this issue. We are trying to find out, is there a possibility to find ways to make sure that this happens? Actually, we came upon a very interesting project. Karan also was involved in it. We are actually looking at the nursing homes. We believe at some point of time, Ayushman Bharat will, to a large extent, reach the nursing homes. And we believe if there is a possibility that the primary and to some extent the secondary care of a patient happens at this place, there is probably a much better way to manage people at the tertiary care. Because like Shobna put in, a lot of people occupy beds. And if you ask me, most of the time people with complications reach at a place where possibly there is very little hope. And I'm not saying doomsday, but basically what you're saying is you're actually doing a little bit of salvaging job rather than trying to do preventive care. So my message to the audience, and at least working with the various partners, is yes, we should collaborate. Look at pharmaceutical companies as people who can really honestly start working towards finding a solution when it comes to the three big mantras that the government is talking about. How do we solve access? How do we solve affordability? And also how do we solve availability? And I think we are up there. We have got few projects. We strongly believe there is value in creating those bridges and making sure things happen.
So, do you have a view on price controls that this government has brought in last 5 years, 6 years?
I think good to some extent. And like I said, pharmaceutical companies generally we also try to adapt. We also believe that the sections of society needs to have some sort of care which is possibly available at the primary level itself. I can give examples about ourselves. We actually have a product at every price point, and we believe.
How can you have a insulin for the poor, insulin for the middle class, insulin for the rich?
I wouldn't say that. What I would say is you would have the latest innovations coming at a price, but you also have products which is your old legacy, strong, good products which already work.
Right.
And we strongly believe we should not take it out, because there is always this urge once it comes under price control, is it viable or not? But I think for a company like us, it is very important to address this issue of viability, and for us to keep those products. And let me tell you, those are 70% of our business, and that we still make sure that we have to keep them running.
I think all of us have reported this story, so have we. Sure. In fact, the reporter who did that is sitting there for us. You have a new drug now. It's a new diabetic drug, which I'm reading a lot of good stuff about. But as I understand, it will still take a fair bit of time before Indian patients can get it. So is there an issue with the gap that exists between FDA approval or international approval of a new drug and then its introduction in India? Is it healthy? Can something be done about it? Because if it's not done, you get it from outside. Sure. And the rest will suffer. In any case, your business will suffer.
Shekhar, very good point. Actually, that we have seen globally, we would have launched those products in India within a year of FDA launch. And that is primarily because we used India as a clinical trial hub, not because it is cheaper to do clinical trials here, but you get a diverse data points which possibly the Indian pool can contribute to. Currently, Novo Nordisk believes in the fact that India has to be 10% of the global clinical trial load. And that becomes a very strong candidate for us to launch the drug very, very early. Now, if you're talking about Rybelsus, which is a new oral protein, I know we are just about in the process of launching this product, at least in the US. And I'm very sure if we have the right mechanics and the right price points and the right strategy, we might have it as early as possible. It's not simply, and we have demonstrated in the past.
No, but how does the Indian regulatory system work?
I think so pretty easy if you look at it in a way. If you try and very early start working on the clinical trials, you have a better chance to have your product early.
So have you been carrying
Yes.
out trials already?
Yes, yes. We
All
are,
right.
even on oral semaglutide, we already have a large number of
On
data
oral
points.
what?
Semaglutide, which is this
Right.
oral protein,
Yes.
which we are going to launch globally. We already have a large number of data points from India.
Well,
4 or 5 trials
I
already.
can keep chatting with all of you, but let me now turn to the audience. Please raise your hand, introduce yourself, and ask your question. No comments, please question. Yes. Or if there's a comment, keep it very short.
Hi, I'm Ashwin Naik. I set up India's first rural hospital network. My question is, the discussion has been around largely doctors and hospitals. What is the role of the community health workers, in particularly in primary care, that we are missing in this conversation?
I think, Matthew, will you take this?
Sure. I mean, I can start, but I'm sure others
Yeah,
will
sure.
have views as well. I mean, so I think our experience has been that they can play lots of roles. For us, part of it is distribution. So we've done partnerships in Bangladesh with BRAC, the world's largest NGO, to actually sell these scratch cards through their community health workers alongside other types of products. I think there's huge potential, especially as we look at NCDs. What is the role of the community health worker in looking at screening and adherence around therapies for NCDs? I also would say at the same time that there's a capacity issue. And I think we need to also confront this issue around saying, what is that level of capability of those community health workers and how do we upskill them? Because I would say our experience has been it's pretty uneven as far as what they're able to do, especially compared to what you would get in a tertiary or secondary care setting.
If I can respond, we did a couple of things in 3 states in India. We actually run the CSCs, what they have, the community service centers in villages. And so we trained nearly 40,000 health workers and upskilled them. And here's where this point of care devices will start making a big difference. Can you imagine that now you can do the cervical cancer check with an iPhone? There's a device to it. We're doing point of care of HB1AC tests. So, and then anemia is a big one. So some of these, I think, are going to get more sophisticated, but basically we've helped them to
How
work
do you do a point
telemedicine.
of care HP?
They
Somebody
do
comes and takes your blood sample?
they take,
I
they do a prick. It's not a blood sample. It's
I
only
see.
a finger prick that now you're able to do, or you're able to do, you said the touch and feel. So the health workers are trained to do this and communicate on the telemedicine. So with the
I
specialists.
think this is so
something
fascinating that we can
do.
go on, but there are
Yeah.
questions. So you have a question, and please keep your question short because we have to leave time for Indu. He has the most interesting case
Hi,
to
good
make.
morning. My name is Sadhvir. I run an early stage fund and we've made investments in healthcare. My question is more on holistic medicine. When we look at India's medical history, we talk Ayurveda, homeopathy. I know Polo's done some good work. I know Ishman Bharat's talked about it. But maybe from a point of the rest of the view, where does that stand?
Thank you for bringing it up.
Does anybody want to take it? Take it up?
We've really tried. I can tell you.
I
that
think she accepts a
with that-
compliment.
Yeah.
And I think we can.
No, but we really tried to do stuff with it. But
Right.
but the regulations.
Right, but also I think this government's investing a lot of money in alternative medicine, but homeopathy has not great press globally right now.
And
I
they
think
can't write the prescription.
Yes, question right in the back, and then we'll come to the front row, and then if we still have time, I don't think we will have time for one more, but let's see if we can keep it.
Hi, I'm Nitesh. I'm co-founder of Koyo Labs. We are a medical device company based out of Bangalore. So one big issue we face a lot with hospitals, which you were saying that why all drug companies or tech companies go to US first and then come to India, because hospitals ask us for US FDA and CE approval. They said that if you don't have this, you can't even get inside the hospital. And then when we spend this kind of money and then we see a lucrative market outside, it's more obvious for us to go first over there and then come back. So how to deal with this kind of situation, and what's your view on that?
Can I have Karan? Are you addressing anybody in particular?
Yeah, both from Apollo side and Karan.
Okay,
if
let
you
Karan
can
is
answer.
very bit silent.
No, I think there's a massive mass market opportunity here. I think if you talked about affordability, what you're talking about, your products, your devices will, if you can make it affording, I think this is the country where we need to be using and leveraging and testing the mass market, the affordable products. And I think there is a high-end market for sure, which is the CE mark and the FDA approved. I think there is another segment which is with good enough quality. I think there's an opportunity not only in India, but in multiple other markets. So I think Indu will talk probably about this, but affordability is going to be a huge part of any system. And if you have an affording product, why not?
Question there.
Hi, I'm
maybe
Ivy.
one more.
I'm the CEO of Maya. It's a health tech company in Bangladesh. My question is more for learning from India, which we are seeing that, as Ms. Kamini was mentioning, that you're worried that the whole nation does not become resistant to antibiotic. How is India, in terms of policymaking, addressing that issue of controlling the prescription? For example, we are trying in Bangladesh is to kind of limit the expiry date of a prescription to 30 days. Is there something happening in India that we can learn for share knowledge?
They're working on it. I think maybe Indu, if you want to. But I can tell you it's a work in progress. There's an e-pharmacy regulation which is coming into place. We'll have to see. As of now, there's a huge, every state has its own drug controllers from the center. This has been put into place for many, many years. And most states it works quite well in terms of prescription, and that you cannot dispense without a proper valid prescription.
Just want to add there that that the e-pharmacy bill is going to be coming out, which ensures that every medicine dispensed has to come through a legitimate prescription that has to be uploaded. I think that's a great new policy. It's still in the draft stage, and we're hoping that it'll come through soon. But there's also still a need. I think there's a need for better regulation when it comes to medicine dispensing. It comes to online consultations. It comes to how do we use technology in a more responsible manner. And I think there's still a big vacuum there, a very gray area. Especially telemedicine in India is extremely gray. And the faster we put good regulation in place, I think things will speed up. One of the problems that health has is it's a state matter, and each state deals with it very differently, making it extremely challenging for innovation to actually take place.
I think I'll give the last question and then Indu, your turn.
In the world over, people are talking about population health and trying to get into preventive medicine.
So tell us your name.
Choco Valiappa, V Technologies, involved in population health in the US and in terms of managing the risks and of the patients and trying to minimize the risks. So would love to hear from the panel on how India's, and also from Mr. Indu Bhushan.
Does anybody want to respond to this here?
We did a great study with Microsoft, and this is being published all over the world. We use longitudinal data and latitudinal of 50,000 checkups over the last 10 years in Apollo using that data. And we actually brought out a study that does a health risk assessment ahead of a predictive that Microsoft is now so excited about. It's been published. It was recently put in, in San Francisco in their conference, and they're so excited about what can happen. And Indians have a predisposition to a higher systolic rather than the rest of the world. So these are studies that are actually coming about when you look at population health, but you would also bring out disease patterns of different states, from northeast to, the ones that are vulnerable to different antibiotics.
Karan was talking about in terms of trying to incentivize people to not get sick, like what you said.
Okay, Indu, I think you should take the floor now. And I know we are left with exactly 10 minutes, and this is WEF time. So all 10 minutes are yours. I will sacrifice my closing remarks. I think you shall all be deprived of my closing remarks.
Thank you, Shekhar, but I'll very generously give you back 5 minutes. I'll just take 5 minutes. And thank you for giving this opportunity. I just wanted to make 3 points. One was that in India, I think for the first time in the last 70 years, we are seeing highest level of political commitment for the health sector. I have not seen that, or actually none of you would have seen that in many years, many decades. And the Prime Minister himself is keen that we improve the health of our population, and the amount of time he devotes to the health sector. We recently were marking our first year of operations, and he spent 2 hours with us. And before that, in UN,
he spoke about health, and he was part of the part of the panel supporting UHC. So we are at a time when India is serious about health sector. I think for the first time probably. That was the first point. Second point is that irrespective of what we do right now, there is a momentum, and the demand for healthcare services is going to rise, and I have a feeling rise exponentially because of many factors, but I'll just pick out 4 factors. 2 factors outside the health sector, something's happening, and 2 factors within the health sector. Outside the health sector, one thing which is happening is aging of population. So even if our age-specific rates for cancer and cardiovascular diseases remain the same, because by the factor that there's a momentum going and people are aging, we'll have more cases of cancer, more cases of disease, NCDs, and from 1990 to now, the number of cancer cases have doubled, not because the incidence has increased, but because the population has aged. So we'll see greater demand for these services because of aging of population. And second thing which is happening outside the health sector is the increasing incomes, aspirations, and people want to get more health care in general, because now all over the world we've seen that health care is a luxury good. When incomes increase by 1%, demand for health care increases by more than 1%. So because since we are growing by 6, 7, 8%, we are going to be seeing an increase in healthcare demand. So that's going to happen. But within the healthcare, what we're doing is going to have a great impact on the demand for services. One is, very ironically, we are strengthening our prevention. And one would argue that prevention is going to reduce demand for healthcare. Actually, the reverse is going to happen for next 10 years, because when you focus on prevention, you're focusing on screening. So all those cases of cancers and cardiovascular diseases and diabetes, which were going unnoticed now, you will see a tsunami of those people, those cases coming out, and they'll go for treatment. So that's one issue. Second is Ayushman Bharat, this demand side financing. Those 500 million people, 50 crore people who didn't have the paying capacity and never thought of going to services, now have the paying capacity. They have that rupee in their pockets to go and seek services. So we'll be seeing that demand, increase in demand. So next 10 years, if you are in the health sector on the supply side, it's a great sector to be in, because you will see exponential increase in demand for services. Now, the challenge for us, the third point, coming to third point, our policymakers, is how to make those services available at affordable cost. Because what we'll be going to seeing is that services are not available for the current demand. And we see, if you go to AIIMS, the kind of lines you see there and are like seen to be believed. So now, how to provide quality services at affordable cost is the challenge that we are going to be seeing, and how to go through with that, or how to ensure these services is something that we'll tackle. And many of the things that we discussed today, that innovation, technology will have to be the part of solution, but also a major part of solution will have to come from government. Right now, government spends about 1.2% of GDP on health, which is among the lowest in the world. I'm not talking about the neighborhood South Asia. I think out of 191 countries, we rank about 180th in terms of the amount we spend. So our policy, health policy of 2017 says that we will increase the spending to 2.5% of GDP. And so it's easier said than done, because once you have to increase amount of the budget for health, you have to decrease it somewhere else. So it's a zero-sum game. So if we can increase this budget for health and more than double it in coming 3, 4, 5, 6 years, obviously this is going to help. But at the same time, we have to seek support of the private sector as well, which has been part of solution, part of the puzzle for the health sector for a long time. 70% of treatments are done in private sector. And so we will be looking at collective bargaining. And as I think issue came up, that if we can provide volume to private sector and in return they can reduce prices, that would be something that we'll be looking at. But innovations, technology will have to be part of solution. And lastly, improved efficiency and redistribution, because right now, if you see, while we have, we need to increase number of doctors and services, but if you look at where they're located, there's a huge skewed distribution right now that most of the services and doctors being available only in large cities. And if this distribution of demand, and that has followed demand because demand is also there in these large cities. So once we've distributed demands and created demands in rural areas and tier 2, tier 3 cities, I'm hoping that supply will also follow and we'll see that distribution which is much more efficient and equitable.
So, Indu, if I may ask you a question. You talked about private sector very positively. But that's the suspicion you are hit with, that, oh, you are now involving the greedy private sector. Can the state, no, not my words, not my words. I'm supposed to provoke. So how can the state leave the poor for their health care to the private sector whose motive is profit? Greedy or not, profit is good for private sector. So how do you answer that, and how do you bring in safeguards?
You know, it's very funny. Maybe I was telling you this, that, see, if you look at our NSSO data, poor people largely go to the public sector because they can't afford private sector. And people like you and probably me, we go to private sector because we don't trust the public sector, or we trust them in terms of skills, but we don't trust in terms of the maybe hygiene or...
We wait for the best doctors from government hospitals to be tempted out by hospitals like hers, so we can go to them.
So now what we're saying is that, you know, doors of these best private hospitals should be open to poor people as well. But you've raised a good point that are our regulations good enough? Can we ensure that this principal agent problem that we have with the private sector can be resolved and we can ensure quality services? We are working on that through many means. I'll not go into that. But, you know, frankly, if 70% of treatments are being provided by private sector and most of the tertiary level treatment is available in private sector, and then keeping the poor people out of this will not be fair. And we need to connect them, or we need to open doors of these facilities to them. At the same time, we need to ensure, of course, with the private sector that they provide them quality services and they don't charge them too much. And for charging, we actually have we have rates, and that has been the bone of contention between us and the private sector, that we are not paying them enough. So obviously, they're saying that they're losing money while working with us. So hopefully, we can find a sweet spot where they are not losing money, but they're also not charging too much. At the same time, we have this compact that they provide them quality care, not the poor care.
So I think as we search for the sweet spot, the time's up. But I can tell you one of the most important data sources that you can look at is a dashboard in his office. So if you can have the benefit of his hospitality or his colleagues, you can see that dashboard. For me, it's eye-opening. It just gives you, it's just a snapshot of whatever is happening to India's health on a very large basis. So thank you very much. All of you have been marvelous. I wish this was a longer session, but I'm sure there'll be another one soon enough.
Thank you.
Thank you.
Thank you.